further ado, let's introduce our first speaker, who's none other than our co-chair, Dr. Jackie Hill. Dr. Hill just joined us recently at UCSF as an associate professor of orthopedics. She has a keen interest in limb differences, especially in children. And she came here from Texas Children's Hospital, where she was running the limb deformity service in Houston, Texas. And she's currently, her primary focus is to build up the limb deformity service at our Mission Bay campus in San Francisco. So I'm going to stop sharing, and I'll let Dr. Hill take it away.
Good morning, everyone. So excited to be here and start off the conference. Today, I'll be speaking about lower limb differences in children, congenital and non-congenital causes. I have no relevant disclosures. My objectives today are to describe a range of diagnoses that result in lower limb differences and discuss the considerations in evaluation and treatment of lower limb differences, and then explain how these considerations differ between congenital and non-congenital etiologies. So the incidence of congenital causes of limb differences has a wide range depending on the etiology. It can be anywhere from 3 to 300 per 10,000. And most of these are limb deficiencies, with the most common being fibular hemimelia or fibular deficiency, next common femoral deficiency, and then much less common tibial hemimelia or tibial deficiency. Amniotic band syndrome also falls into this category. And even within a singular presentation of a congenital etiology, there is a large spectrum of presentation. So for example, in a congenital femoral deficiency, you can have a relatively mild leg length discrepancy compared to a very large leg length discrepancy with malformation of the joints. Non-congenital causes include, but are not limited to, neoplasm, trauma, infection, which is the picture on the X-ray picture on the left here, Blount's disease pictured on the right X-ray, and metabolic disorders. And similarly to congenital etiologies, within one diagnosis, there can be a large spectrum of presentation. So these images show a spectrum of presentation within Blount's disease. The evaluation of lower extremity differences for congenital and non-congenital causes is very similar. We begin with a detailed patient history, starting with their birth history, discussing nutrition, injury, infection, and family history, and then conduct a physical exam that is both very general to look for any syndromic issues, as well as global malnutrition or different nutritional issues, and then a focus exam looking at the gait of the child or patient if they're ambulatory, their spine, the size and shape of the leg, the range of motion and stability of the joints, the overall leg alignment, limb length difference, and their rotational profile. And then imaging is obtained, including both focused imaging on the joint or bone that seems to be different, and long limb length X-rays, including a scanogram. MRI, CT, or other three-dimensional imaging may be obtained for physial evaluation or to look at cartilaginous joints that have not yet formed or ligaments. It is important to also look at associated physical exam and radiographic findings. These can be helpful for both the diagnosis, for making the diagnosis, and also planning the treatment. So for example, in congenital origin of fibular hemimelia, these patients can have an ACL deficiency, genu valgum, and ankle valgus. And they also can have associated femoral deficiency and missing rays. The imaging on the right there shows a ball and socket ankle joint, which is highly suggestive of fibular hemimelia. And this also applies to non-congenital causes. So for example, an infection, you can see multiple joints involved, and it would be important to identify this on the imaging. Once a diagnosis is made, it can be helpful to use classifications These classifications are most helpful if they can guide treatment and help to predict prognosis. There are many examples of different classifications, but the ones that are being used the most frequently for congenital right now are the Paley classification, as imaged on the right here for fibular hemimelia, and there are other ones for other congenital deficiencies. And there are also several classifications for non-congenital etiologies, as pictured here, a newer classification for Blount's disease developed by Lamont. Once a diagnosis has been established, there are important considerations for treatment that are used for both congenital and non-congenital etiologies. These include calculating the ultimate limb length discrepancy, assessing whether there's an angular deformity, whether there is joint stability, and what is the overall limb function of the patient. When we evaluate a patient who is skeletally immature or has growth remaining, we notice that there is a certain leg length difference, but we anticipate that this is going to change as they finish growing. For congenital etiologies, this difference remains relatively constant in terms of the proportionality, and this is called the rule of proportionality. There are many different methods to use for prediction, and these are relatively straightforward. Predicting a non-congenital etiology ultimate leg length discrepancy is slightly harder, except in cases where you think that the growth plate is no longer working at all, in some cases of infection or trauma. When we analyze a patient, we want to make sure we're analyzing them in both the AP and sagittal plane for angular deformities that need to be addressed. In congenital patients, these deformities are often structural, resulting from malformation of the joints. So lateral femoral condyle deficiency and fibular hemimelia, and congenital femoral deficiency, a ball and ankle socket joint and fibular hemimelia, or a bowing of a bone. In non-congenital differences, the etiology can be secondary to differential growth within the growth plate in cases such as infection, trauma, and Blount's disease. There can be secondary remodeling or fracture in cases of neoplasm. The imaging on the right there shows a patient who has Ollier's disease and had secondary fractures through his enchondromas, resulting in this angular deformity. And of course, there can be malunion through fracture sites resulting in deformity. And then lastly, the joint stability needs to be assessed. This is definitely more relevant in clinical etiology of leg length differences or limb length differences. And in some patients, this may be subclinical or asymptomatic and only detected on clinical exam or imaging. And it is very important to consider the joints prior to performing any limb lengthening or reconstruction. So in conclusion, there are many etiologies of lower limb differences. And hopefully I've started to provide a framework for the evaluation and treatment considerations that we can use to create customized treatment plans. Thank you.